My name is Chris Jackson, and I'm an assistant professor of neurosurgery at Johns Hopkins. In this chapter on frame and frameless stereotactic brain biopsy, we review the indications, procedural setup, standard and emerging technologies, as well as some pearls and pitfalls of this technique. Indications for stereotactic brain biopsy include deep lesions, and particularly those in close relationship to critical structures, making them not amenable to open surgical resection. Diffuse tumors where therapeutic debulking is difficult or impossible, but a diagnosis may guide non-surgical management. Patients who are not amenable to surgery because of comorbidities. Or in cases where decisions regarding a tumor diagnosis will guide subsequent treatment, particularly in cases where molecular substratification may afford access to targeted therapies. Patients that would benefit from early diagnosis, which will then guide the initial treatment strategy in terms of surgery or non-surgical management. And also in cases where alternative diagnoses may be suspected, such as infections or inflammatory processes. The importance of accurately localizing and accessing subcortical structures safely was recognized early in the history of neurosurgery. The first apparatus used to localize brain structures was invented by a Russian professor of anatomy, D.N. Zernov, in 1889. In 1906, Clark and Horsley described a stereotactic method of localizing brain structures in animals with frame-based 3D coordinate systems. However, systematic application of this technique in humans was made possible by the advent of intracranial imaging. In 1947, the first human stereotactic system was introduced based on ventriculography. With the introduction of CT scans in 1973 and followed by MRI in 1980, frame-based systems became widely used in order to generate lesions for treating movement disorders, treat pain and epilepsy, and as well as for the drainage of abscesses and to perform tumor biopsies. The first systems used a polar coordinate system. More contemporary frames, such as the Lexell frame, use an arc radius guidance system. In the latter, the location of the target is calculated in relation to the geometric center, and arch coordinates are adjusted to then reach the lesion. Frame-based stereotaxy has largely been supplanted by frameless stereotaxy, as this technique affords improved patient comfort and surgeon maneuverability without sacrificing safety or diagnostic yield. Frameless stereotaxy is based on registration of fixed points correlating to the patient's head position in the operating room, and then corresponding structures on preoperative imaging. These points can either be anatomic structures or fiducials placed at the time of image acquisition. This technique also affords more accurate operative planning to avoid blood vessels and critical structures. Frameless stereotaxy allows for a very high degree of precision in trajectory planning, such as in this example, where the surgeon uses the planning software to skirt immediately lateral to the lateral ventricle without violating the appendable surface. The setup for frameless stereotaxy involves three steps of equal importance. The first is trajectory planning. An entry point is planned which avoids the dural venous sinuses as well as eloquent cortical areas. The trajectory should avoid vessels, aim to avoid the ventricles, as well as minimize the number of PL surfaces crossed. The target should be entered in a trajectory that allows access to both superficial and deep portions of the lesion in order to increase diagnostic yield. When the trajectory has been planned and finalized, meticulous registration must occur to ensure good correlation between the preoperative imaging and planning and what's going on in the operative field. Finally, the biopsy device has to be attached to the Mayfield clamp or to the patient's skull so as to maximize maneuverability and access for the surgeon. Sampling errors of greater concern with stereotactic needle biopsies as compared with open excisional biopsies because a smaller volume of tissue is acquired with these procedures. The diagnostic accuracy of stereotactic needle biopsy is reported in the literature to range from between 51 to 78%. There are a few important steps, however, that the surgeon can take in order to maximize the diagnostic yield of these procedures. First, the preoperative MRI must be of high quality. Second, during the procedure, every effort should be made to minimize brain shift. This includes minimizing CSF loss, particularly if a trajectory is planned that crosses a ventricle, avoiding hyperventilation, and withholding mannitol and diuretics. For non-enhancing, infiltrative lesions, the surgeon should sample multiple areas along the biopsy tract to increase yield. In addition, adjuncts such as PET, perfusion imaging, and spectroscopy may be useful in deciding which portion of the lesion to target. Finally, tumors with a large volume of necrosis present a special challenge, as biopsying the necrotic area may be non-diagnostic, while steering completely clear of the central portion of the lesion may skew towards a lower grade pathology. Stereotactic needle biopsies are generally safe, but there are some important complications to consider. The most common complication is intracranial hemorrhage. Hemorrhage typically occurs when blood vessels are damaged either along the trajectory, particularly when crossing sulci and peel surfaces, or at the target, when pathologically friable vessels within the lesion are damaged during tissue sampling. Reported rates of hemorrhage in the literature range from 0 to 11.5%. For all patients undergoing stereotactic needle biopsies, 6.9% rate of morbidity, 1.3% rate of mortality, 4.8% symptomatic hemorrhages, 2.9% experience a transient deficit, and 1.5% experience a permanent deficit. Morbidity can also occur from direct damage to the brain by the needle itself. This can be avoided or minimized by taking care in the planning of both the entry point as well as the trajectory. Brain penumbral damage can be limited by reducing the number of needle passes. And again, this comes to planning trajectories that allow for sampling multiple areas along the same pass and minimizing the number of needle passes required to get a representative sample. Finally, preoperative corticosteroid therapy in lesions that have significant edema may be useful in reducing the risk of morbidity. However, the patients should be carefully selected because if lymphoma or inflammatory pathologies are high on the differential, administration of preoperative corticosteroids can reduce the diagnostic yield. The implementation of robotics is making many neurosurgical procedures safer, faster, and more effective. There are generally three types of robotic systems being used in surgery. There's supervisory controlled systems that require the supervision of a surgeon overseeing a semi-autonomous